Welcome to AETCM, the Emergency Medicine channel. 51-year-old male patient presented to our ER with an alleged history of fall from height around 12 feet on his back, followed by complaining of severe back pain and right side chest pain. On initial 10-second assessment, patient arrived in Arrival. We examined the patient, was constant oriented and is able to complete full sentence. Going to primary survey, airway was C-spine is secured with Philadelphia collar. Patient airway was patent. There is no pooling of secretions and gurgling of sounds. Coming to breathing part, saturation is 95% in room air. Respiratory rate is 28 per minute and is complaining of right side chest pains. Bilateral equal air entry. Circulation part, heart rate was 106 per minute and BP was 140/80 and CRT less than 3 seconds. Disability was GCS was E4, V5, M6, pupils 2.5, bilateral equally reacted to light and is moving all 4 limbs. Exposure was temperature was normal, sir. And this pain score of 7/10. We secured 2 large caliber cannula. Through that we can given injection PCM 1 gram IV stat was given. Coming to the adjunct to primary survey, we done a USG EFAST that came to be negative.
USG EFAST is fine. Primarily, as you told, what is the problem here? Breathing, right? Patient is having tachypnea, respiratory rate of 28, with a mild hypoxia, 95% on room air. The patient is complaining of chest pain. You are telling about a case of fall from height, isn't it? So, mechanism of injury anyhow is coming only, but at this point your only problem is in the breathing part. So as per ATLS, you get a positive finding, you treat the positive finding, then you go forward. So when you say tachypnea with 95% saturation, you should start oxygen at that point. You should start maybe nasoprongs 95%, right? So you don't have significant hypoxia. You start a nasoprongs at 2 liter or 3 liter oxygen, then go about the same. And adjuvants to primary survey will be primarily a arterial blood gas because you had a hypoxic event. Arterial blood gas will be primarily. Secondary, what will be your important accessory? Secondary trauma series X-ray, especially chest X-ray, isn't it? Here trauma series X-rays are indicated because first of all fall from height, second of all hypoxic injury. You want a chest X-ray to rule out pneumothorax, rib fractures, hemothorax, isn't it? So you want a ABG, you want a chest X-ray. What is the third important accessory? No, it will be ECG because you have a fall from height with suspected lung injury. So lung injury comprises not only lung, it comprises surrounding rib cage. Since rib cage injuries you should suspect, their patient can have pericardial effusion. So that can also cause breathing difficulty. So here heart rate is not very high. That is the negative point for pericardial effusion, but a ECG should be taken to rule out pericardial effusion so that you can say cardiac arrhythmia, even not only low voltage complexes for pericardial effusion, cardiac arrhythmia should be ruled out. So thoracic trauma, we are dealing with 4 different organs, isn't it? 4 different organs. What are the organs? One is our
heart, lungs.
Yeah, so respiratory system. So the respiratory system is 2, airway and breathing. So airway is separate. Airway is not our oral cavity alone. It comprises up to trachea. So till trachea. So airway is there. Then ventilation. So lungs is there. So you have a and B component in tracheobronchial and lung component. Then you have circulation. Circulation is divided into 2 different. One is cardiac and great vessels. You are having a thoracic trauma. So you have the arch and you have the great veins. Both these injuries should also be kept in mind. So circulation is not only heart but the vessels also. Then you have disability. Disability wise, what you are looking for? Spinal trauma, isn't it? Yeah, spinal cord injury due to a spinal trauma. So this many components is what you are looking for in a history of fall with suspected thoracic injury. Why we are saying thoracic? Because of the hypoxic nature of the thing is why we are saying, because patient is moving all four limbs. So we are not suspecting a spinal trauma here. Patient is only having breathing difficulty, isn't it? But hypotension is not there, tachycardia is not there. We have to rule out these conditions. So ABG to look for hypoxia, ECG, chest X-ray to rule out hemothorax and refractures. Okay, and you will take a ECG to this thing. Then you can do the ultrasound here, because since hypotension is not there, your ultrasound can be done at primary accessory at the last. Actually, if needed, you can do the E-fast at the end of secondary survey also, because right now you do not have a hypotensive episode. So you take ATLS. ATLS haven't clearly told you where to do E-fast. They are told there is a component called E-fast. Okay, where to use it is physician decision. For example, if you have a circulatory problem patient who is having tachycardia with hypotension, E-fast should be done on circulation, not as an accessory to primary survey. Why? Because when you have a hypotensive trauma patient, it's a unstable trauma patient. So if it is a E-fast positive, that is abdominal hemorrhage patient with shock, this patient should go to OT, isn't it? To identify that, you have to do E-fast during circulation. So it's not an accessory anymore. But if you don't have, but you have suspicion of circulatory collapse, or if you have, for example, stage 1 or stage 2 shock features, patient is not like unstable, you don't have to do it in circulation. You can start fluids, and on accessory, as an accessory, you can use E-fast. Okay, so E-fast we do for every case, but that doesn't mean E-fast always comes in adjunct to primary survey or accessory to primary survey. Okay, so but E-fast we have to do. Okay, so what were the reports?
You was chest ECG was taken, it was normal. Chest X-ray was showing right side hemothorax, associated pneumothorax also. Then USG E-fast repeatedly done becomes positive.
E-fast, if you say fast, it's fine. E-fast we would have picked up, right? Because X-ray is already showing hemothorax, that you told. So if a X-ray shows hemothorax, that is more than 300 ml, isn't it? So a E-fast should be already positive, isn't it? E-fast requires only more than 100 ml to be positive in hemothorax. So X-ray shows hemothorax, then definitely our ultrasound we have to pick up. If we have not picked up, what may be the caveat? Why we might not have picked up a hemothorax in ultrasound? You told X-ray showed hemothorax. That means costophonic blunting, right? You are saying costophonic blunting as hemothorax. Correct. So, but if your ultrasound or E-fast didn't show hemothorax or blood inside the thoracic cavity, what does it mean? Posterior collection. So you are looking at a posterior collection. Because patients are supine, it may not always be very evident in the diaphragmatic angle. If you do, you may have to go a bit deeper to identify a posterior collection. So that is a possibility that why your E-fast didn't show that much. this thing. So in this part, so in primary survey accessories, you have a hemothorax, pneumothorax, isn't it? So and right sided chest pain is also there. So what do you what do you think happened here?
Mechanism.
Yeah, mechanism.
Patient fall on to right side and with his
Most
back
probably
was-
must have caused rib fractures
fractures.
causing secondary hemopneumothorax. Now, how do you proceed this case? How do you like what is the management that you are going to give?
Initially, patient is suspect pneumothorax. We can do a needle.
No, you have pneumothorax, right? You X-ray has taken, you have proven pneumothorax, proven hemothorax. How do you proceed?
We can use ICD, or patient is very tachypneic. We can do a needle aspiration.
This thing, this case you tell.
In this patient, we put on ICD,
Okay. So what type of pneumothorax is this? This is a closed pneumothorax. This is a closed pneumothorax, right? You do not have any external injuries to say open pneumothorax, and patient's vitals are very stable. So this is not a tension pneumothorax. So this is a closed pneumothorax which is evolving over time. Okay, it can very well be a closed pneumothorax which is non-evolving also. That means whatever pneumothorax is right now there, it may not evolve also. Do you have to put a ICD here or not? Like my question is, see, your saturation is 95%. It's not very low. Your respiratory rate is 28, not very high. This patient had a major trauma, isn't it? Your pain score is 7 out of 10. So this tachypnea can be due to pain also. You are telling that here there is a pneumothorax. I am asking, is ICD insertion a emergency in this case or not? Or do you want to wait and watch?
Patient had pneumothorax, better to put ICD.
Why? Why can't we wait? Patient saturation is okay with your 2 liter nasal prongs right now. If patient is having 100% saturation, after PCM patient's tachypnea has come down, with oxygen patient's tachypnea has come down to 20 per minute. So right now vitals are stable, no? Why you want to put ICD? What is the use of ICD in this patient?
Lung can expand.
We are concerned about ongoing hemorrhage. So at this point you have got a hemothorax. What about whether there is a lung laceration? What about there is a arterial injury in the lung? So we want to know ongoing bleed. To know the ongoing bleed, we need a ICD, not for pneumothorax but for hemothorax, so that we can understand the ICD output. Okay, so you have massive hemothorax and non-massive hemothoraxes. No, this is not massive hemothorax. Definitely patient's vitals, everything is stable. But if this patient, after putting ICD, there is a continuous flow of blood through the ICD, means what? There is an underlying lung injury from where blood is oozing out. So then you can understand that the patient requires a CT scan with a thoracic CT with angiogram to assess any vascular injury or lung laceration in the thoracic cavity. To understand that, you need to put a ICD, or else you will only know when the patient desaturates and goes into hypotension. Because of that, ICD is indicated in this patient. So once you put ICD, you are going to monitor output. Fine. So in this patient, you have put ICD, no? Any ongoing blood loss was there?
No, sir.
No, it was not there. What about patient's symptoms? Improved with this thing? Okay. So basically this patient had a most probably rib fractures with a hemopneumothorax, which you treated with ICD insertion. Now, after your primary survey and secondary survey, if this patient's saturation worsened in maybe like 4 or 5 hours later, patient is now again having tachypnea, respiratory rate of 30, 35 with a saturation of 95, 94%, what will you suspect?
Tube blockage
So you have to troubleshoot now, because you already know a hemopneumothorax for which you have done a ICD insertion. Because ICD insertion is there, your first things to rule out should be ICD blockage. But even then, as per ATLS, you should start from ABCD. The primary survey should be re-examined. The whole idea of ATLS is not to jump into conclusions, is to go in a systematic way. So if this patient desaturates after 3 hours or 4 hours later or even 6 hours later, you are going to repeat primary survey. That is your airway, C-spine, breathing, circulation, like that. So in coming breathing, your ICD, whether obstructed or not, clamped or not, whether on line or not, or whether water seals air outlet is closed off or not. If pneumothorax is there and ICD's water seal containers, air outlet is closed, air will again stuck there and cause pneumothorax only, right? So these things will troubleshoot. But if ICD is working normally, but patient is complaining of breathing difficulty, what will you suspect? What is the other associated condition of thoracic trauma which is usually present with rib fractures?
Flail chest.
Flail chest. Flail chest is a condition. So what is flail chest? Can you define flail chest?
It is the paradoxical movements of the fractured ribs. Normally it will move on during inspiration, it will move out, but during paradoxical movement, it will opposite will move. So it causing.
True. So in a normal breathing, you have bucket hand movement of ribs. So you have ribs moving outward and anteriorly, right? You have outward and anterior, upward movement is what you have. But when a rib fracture is there, flail chest, in definition wise, what is it? It's
consecutive 3 to
consecutive ribs, a rib which is fractured in 2 distinctive places with at least 2 consecutive ribs, fractured in 2 distinctive sites. That is the criteria for a flail chest. So that there are segments, at least 2 segments of ribs which is not connected to sternum or to the spine. That means that segment of ribs is not participating in rib movement. So when the other ribs are moving naturally, that is normal natural movement is anterior, upward, natural movement of ribs happening, this segment of ribs will not move because it's not connected. That we see as going inward, which we call as paradoxical movement. It's not actually going inward, it's not moving. The rest of the ribs are moving. These 2 ribs are, or 2 or 3 or 4, whatever, how many other ribs are associated, those ribs are staying in the same place. That is flail chest. So, what is the problem with flail chest?
If multiple ribs is there, lung cannot able to expand.
Yes, since the ribs, those areas ribs are not moving, that area of lungs is not able to expand properly, so lung collapse will happen. But when we say flail chest is one of the conditions that will always be present from the moment patient comes to emergency, right? Flail chest will not develop after 4 or 5 hours later, isn't it? Because already fracture is there, isn't it? So flail chest we will have to identify during our primary survey of breathing itself. But here we are discussing a condition in which there is rib fracture, there is hemothorax, pneumothorax, we put ICD, patient improved. But after 4 hours, 5 hours, 6 hours, patient is again developing breathing difficulty. That is a worsening condition. So my question is, what other condition, what other lung injury worsens over time or presents over time? Tell. Lung collapse. Correct, lung collapse. But lung collapse due to what? you have either mechanical conditions or inflammatory conditions. Mechanical flights, as we told. What others? Lung contusion. So lung contusion has a very high occurrence rate when there is associated rib fractures. See, what is rib? Rib is a calcified bone, right? So whenever there is a external force acting on it, the rib will transmit the forces to the nearest junctions, that is either to sternum or to the spine, and in between the rib, if there is a tension point, rib breaks. So where does the force get delivered to? It gets delivered to the underlying lungs. So that can cause lung contusion. So lung contusion, like any other tissue contusion, is hemorrhage into the lung parenchyma, which worsens over time. So if the extent of presentation of lung contusion will be depending on the extent of lung contusion. If you have multiple rib fractures, lung contusion will be present at presentation itself, because huge area is affected. But if one or two rib fractures is up there, our patient is having some other confounding factors, like here. The patient initially had tachypnea due to hemo pneumothorax, which will make the patient symptomatic much more faster than lung contusion, isn't it? So, patient initially had hypoxia due to hemopneumothorax, then also lung contusion will be there, but it is evolving. But already by that time, the pulmonary hemothorax and pneumothorax is there. That's why initially after ICD, the patient improves, because the initial insult is treated. But after some hours, as pulmonary contusion worsens, as hemorrhage worsens, the affected alveoli gets filled up with blood and debris, causing collapse, causing that much area of lung to not to participate in ventilation anymore. So you have got a dead space. What will happen? Decrease in lung volume, causing decrease in tidal volume, causing hypoxia. So patient will start saying that breathing difficulty. So ideally you are supposed to reassess the primary survey, check airway, breathing, and in breathing you identify any worsening of hemopneumothorax, that is non-functioning of ICD. If that is not there, then the question comes whether it is cardiac or another lung injury. So cardiac, you have to take a ECG or do a echo and rule out pericardial effusion, because pericardial effusion also evolves over time. If not, you have to go for CT thorax, and CT thorax will tell you lung contusion. What is the treatment for lung contusion? Mainly supplemental oxygen. Like any hypoxic injury, supplemental oxygen is the treatment for lung contusion. But if lung contusion is significant enough, it can mimic ARDS like condition in which patient is having severe hypoxia. You may have to put the patient on positive pressure ventilation to prevent alveolar collapse. But the problem is, the more positive pressure ventilation you give, there is a possibility of increasing pneumothorax. So ICD has to be inserted if patient already has ICD. So initially when we told if this patient requires ICD or not, if you suspect lung collapse or lung contusion, and if you are planning to put positive airway pressure, you should always put ICD before starting off, and start the patient on NIV, start on a higher pressure point to maintain tidal volume, and analgesia. That's all you can give. Over time patient will improve. But pulmonary contusion is a condition you have to keep in mind, because pulmonary contusion cannot be diagnosed as it is. You have to rule out other conditions to say pulmonary, to diagnose a patient to have pulmonary contusion. Okay. In ATLS thoracic trauma, there is something known as life-threatening thoracic injuries and non-life-threatening thoracic injuries. So, total thoracic injuries are around 12 or 14 in number, in which 6 are life-threatening thoracic injuries, and one of that is lung contusion. Okay, so look into that. Okay. So in this, once ICD is inserted, patient was fine. No, secondary survey was normal.
No.
Patient was admitted and
Conservatively management done.
and discharged.